We looked at the results of a specimen stain and listed the most likely organisms present in the specimen. We described the basic process of microbiology testing. We identified the normal human flora and their role in infectious diseases. And we explained the antimicrobial stewardship process for initiating, monitoring, and streamlining effective and safe antimicrobial therapy. Now let's define sepsis and septic shock and explain the cascade of inflammatory and hemodynamic changes that drive organ dysfunction. Sepsis is recognized as a syndrome of acute organ dysfunction due to a dysregulated host response to infection. So in other words, you need to have infection present or suspected at least in order to have the syndrome of sepsis in response to infection. Now, there has been several definitions of sepsis over the years. The very first definition of sepsis was developed in 1991, and the definition was essentially an infection that could be a suspected infection plus 2 or more SIRS criteria, and I will shortly explain what SIRS criteria are. And the same definition continued in the second revision, in the second version of the sepsis definition in 2001. However, sepsis 3 definition, which was developed in 2016, significantly changed this definition. So essentially, a suspected infection plus 2 or more of the SOFA score, which again I will discuss shortly. So that's the definition of sepsis. And then we have the concept of septic shock. This is a subset of sepsis cases where despite adequate fluid resuscitation, patients have hypotension requiring vasopressors to maintain a mean arterial pressure of at least 65 millimeter of mercury and have an elevated serum lactate of at least 2 millimoles per liter. So essentially, you can think of someone who develops infection, but first of all, not everyone with infection will develop sepsis. So a subset of people with infection will develop sepsis, and not everyone with sepsis will develop septic shock, but a subset of people with sepsis will develop septic shock. And at this point, people with septic shock, they are in critical illness, and that can lead to death. So a large number of patients with septic shock essentially die despite adequate treatment. Now let's take a look at the SIRS criteria. SIRS stands for Systemic Inflammatory Response Syndrome, and there are 4 things to look at. Essentially, the first thing is temperature, so either a temperature of greater than 38 degrees Celsius or a low temperature less than 36 degrees Celsius, so essentially a fever or hypothermia. The second is heart rate of more than 90 beats per minute. The third one is a respiratory rate of more than 20 per minute, or in case of if the patient is in a ICU and you have access to more invasive measurements, you may have the arterial partial pressure of CO2 less than 32 millimeters of mercury. And the fourth one is a white blood cell count of more than 12,000, or too low of a white blood cell if it's less than 4,000. Alternatively, you can look at the immature white blood cells. So if the percentage of immature cells is more than 10%, that's also an indication of this inflammatory response. So if the patient has 2 of these 4 things, is considered a positive SIRS criteria. Here's the SOFA that the latest definition of sepsis is using. So the SOFA score is very comprehensive. So you can see that there are several categories to look at. So you look at respiration, coagulation, liver function, cardiovascular function, central nervous system, and renal. And then each one of these, based on these values, you get a score of 0, 1, 2, 3, or 4. And then essentially you add them up and you get the overall SOFA score. So the definition of sepsis, well, first of all, that SOFA is quite complicated. So, if you're screening patients, it's difficult to just off the top of your head calculate somebody's SOFA score. So, and there are online calculators that people can use, but there's also the quick SOFA that's intended for screening. And people also use the SERS criteria for screening purposes because it's very easy to remember the SERS criteria. It's only 4 things. Whether you use SERS criteria or QSOFA, and there are other tools out there that we will not discuss, but essentially that can screen for patients and identify people who are more likely to end up with critical illness. So if a QSOFA, which has 3 things, so essentially you look at respiratory rate, mental status, and systolic blood pressure. And the cutoff values for these is a respiratory rate of at least 22, so 22 or more per minute. Mental status, that essentially means if there is altered mental status. Systolic blood pressure cutoff is less than or equal to 100 millimeter of mercury. So if the patient has 2 or more of these 3 things, then essentially you will say that they are at risk of having organ dysfunction, and you definitely need to calculate their SOFI score. And then once you calculate the SOFI score, which I showed you on the previous slide, if the score is at least 2, that essentially defines sepsis. This is assuming this is in someone who has suspected infection. So having the infection is key, because if you calculate this in someone who's not suspected to have infection, that doesn't mean they have sepsis. And then once somebody has sepsis, in order to define septic shock, they should, if they have hypotension, the first response is to give them fluids. And if the fluids doesn't resolve the low blood pressure and they require a vasopressor agent to maintain a MAP of at least 65. And if the serum lactate level is at least 2, the combination of these 2, both of them are required to meet the definition of septic shock. And that essentially defines the patient as having a septic shock. Now, when you look at people who have organ dysfunction, again, not everybody will have an infection, and not everybody with infection will have organ dysfunction. So you have this crossroad of sepsis where people have infection and organ dysfunction, and then a subset of that will have septic shock. And it's difficult to prove that everybody with sepsis has an infection, and that's why we say suspected infections. So about half of the patients, we will not be able to actually grow some bacteria or other organisms in culture. So that's why we say, a suspected infection is required for definition of sepsis. Now, major organ system to monitor sepsis, because we talk about organ dysfunction. So these are the organs. So of course the cardiovascular system, and this is where hemodynamic instability comes in. And then we have the liver. So we have hepatic system that can have dysfunction. We have the kidneys, so the renal system. We have neurological system, so altered mentation is a concern. Of course, respiratory system, as people will have oxygenation issues, and hematological system where, for example, there is coagulation issues, platelet count issues, and so forth. Now, the core of the pathophysiology of sepsis is twofold. On the one hand, there is pro-inflammatory response. So essentially, in the acute setting, inflammation is a defensive mechanism for the body when fighting infection. And then on the other side of it, there is somewhat immunosuppression involved with this patient. So there are two things going on, when we look at the big picture, and there's pros and cons of each. So for example, the pro-inflammatory response, the benefits of it is that there is local activation of defensin and cytokines to fight infection. There's activation of phagocytosis and killing of cells, local endothelial activation for increased cell recruitment. On the downside, there is systemic cytokine release with endothelial activation and hypotension. So essentially, these make the vasculature leaky. So as fluids leak out, blood pressure can drop, which is can be detrimental. systemic activation of complement, dissemination of intravascular coagulation, and organ dysfunction. And then on the immunosuppression side, the beneficial side is that there is regulation and control of inflammation, because too much inflammation can cause damage. So this immunosuppression is going to calm things down, calm down the storm, and increase in tissue repair. The downside of that is that now you have immunosuppression, so people are more prone to getting other infections. So not necessarily the infection that caused sepsis, but now that you're going to have opportunistic infections that can be problematic in these patients. So when you look at the timeline of as the patient's sepsis develops, early on there will be systemic inflammation that can lead to organ failure. So you have some early mortality as a result of that. So this happens within hours. And then as as the body struggles to balance the pro-inflammation and anti-inflammation to maintain homeostasis, there is ongoing immunosuppression that can result in delayed mortality, which happens over the next few days. And then, of course, there are longer-term consequences. So, weeks or months to follow as the patient, even gets discharged from the hospital. There could be a long-term mortality, which can make overall mortality up to 50 to 70%. So this is a very, serious condition. And again, every individual responds differently, because there are many factors that determine how a single individual responds to infections. So, for example, age has a factor, comorbidities, if the people have other viruses in their body, how good their microbiota is, and of course the treatment. Did they get the right treatment? Did they receive other interventions? These all affect essentially how these outcomes unfold in different patients. And when you consider all of this, so in this picture we're looking at the end result in the human body. And this is important because as pharmacists, we need to adjust medications in this patient. So, if you look at this timeline, so when the insult, which is the infection, comes, and there's a cytokine storm, so this is the body's immune response to the infection. And then there's the effect on various organs, so the liver, neutrophils, lymphocytes, endothelium, cardiovascular system. And the changes that occur, for example, in the GI tract, there is impaired motility. So essentially, if things are moving slowly, absorption could be impaired. So if you're thinking of oral medications, for example, they may not be appropriate because they may not be absorbed immediately in these patients. There is changes in blood flow. There is capillary leakage. There is changes in protein binding. And because of that, distribution of drugs, so volume of distribution will be different in these patients. So that, all of that affects dosing of certain medications if they are affected by this. Metabolism, so if the liver and if there is hepatic dysfunction and renal dysfunction, metabolism of drugs could be affected depending on a specific drug. If they are metabolized by the liver, so the dose need to be adjusted, or if they are renally cleared, they need to be adjusted. And of course, some of our interventions affects this pharmacokinetics in the patient. So if we're giving a lot of fluids, if there is renal replacement therapy, or if there is ECMO, all of these affect various pharmacokinetic parameters that can affect dosing of agents, and those are extremely important to keep in mind for us as pharmacists. That concludes this presentations. Make sure to like and subscribe. Until next time, take care.